Dear professors, dear colleagues, dear students, dear doctors, we welcome you at our second setting at our April issue of ICERN Web Library of Neuropsychiatry. Today's topic is bipolar disorder, and we will talk about what do we know about the mixed state, and we are welcome Professor Giuseppe Tavormina, and we also will be talking about digital mental health technologies which we can use, and Associate Professor Alexey Pavlichenko will deliver this very interesting lecture. So it's my pleasure and honor today to introduce Professor Giuseppe Tavormina, who is the General Secretary of European Depression Association, who is the President of Psychiatric Studies Center and Senior Research Fellow in the Association of the University of Cambridge and United Kingdom. And Professor Giuseppe Tavormina will be talking about bipolar disorder and mixed states. You are very welcome to the stage, dear Professor Tavormina.
Thanks so much, Daria, and I'm honored to take part to this interesting sequence of congresses and presentations organized by the International Center for Education and Research in Neuropsychiatry, and I really am honored to take part. My presentation will be focused on the mixed states and the notion of the mixity. But first, let me remember Professor Akiskal, the most preeminent conceptualizer of bipolar disorder in the world. A few months ago, he passed away. I feel obliged to thank Professor Akiskal for everything he did in the field of bipolar mood disorder, for everything he gave to all us psychiatrists, and for everything he gave to me as professional level. He also participated as honorary president at the first three of my congresses organized in ISEO in 2003, 2005, 2009, and this picture you can find from the last his participation in ISEO congresses. I say now to him, Dea Agot, thanks for everything. Usually, who follows my presentation across the countries in Europe, usually this is the first slide I present to talk on bipolar mood disorder, because this is the basic slide to catch our evaluation on what means the instability of the mood. The depressive episode is only one phase of a broader bipolar spectrum of mood, in which the instability of the mood is the main component, so that the major depression, so-called major depression, is not another illness. It is the phase of the fluctuation of the instability as the wave of the sea, the instability of the mood, in which this yellow line, you can find the picture, describe the modality in which the mood can go down in depression phase, go up in the hypomania, hyperthymic phase, and go also with the black line describing the tensioness, the restlessness, the agitation, describing the mixity and the mixed states of the mood. Akiskal presented in 1999 his perfect scheme of all bipolar disorder. This is perfect, probably a bit complex for the clinician, so that I revisited this scheme to make it more usable and easy for all clinicians. In this scheme, I put all kind of bipolarity mood disorder, all kind of mood disorder, except then PTSD and except then maladjustment, stressful disorder. I put inside, from one side, the acute mania, and in the opposite side, the unipolar depression. inside between one another, all modality of instability, in which you can find the bipolar 1, bipolar 2, the cyclothymia, the temperament, because even if sub-threshold, but the temperament are the first steps of the bipolarity, and of course, they written in dark yellow, the mixed states, the irritable cyclothymia, mixed dysphoria, and agitated depression. On the left, on the right of the white arrow, you can find the possibility, evolutivity of this illness in natural or iatrogenic evolutivity. I talked about the temperaments. Why? Because they are sub-threshold, subclinical forms of the bipolar spectrum, and they are continuous kind of presentation of the characters, mood, peculiarities. It's important to catch early for the clinician the temperament, because starting from the temperament we can understand better the modality of evolution of the bipolarity. We know that depressive, hyperthymic, and cyclothymic irritable temperament. I divided the temperament in 3 groups, even if several in scientific literature describe and divided them in 5 subgroups. I divide them in only 3 groups because the cyclothymic, irritable, and anxious, in my clinician experience, is one group similarity, because the common part is the instability, the agitation common to the cyclothymic, irritable, and the anxious temperament. The depressive temperament, we know the patient presenting gloomy, humorless, or incapable of fun, given to worry or pessimistic cognition, introverted, passive, lethargic, habitually long sleeper, preoccupied with inadequacy, failure on negative events, skeptical, self-critical, overcritical. In the opposite, the hyperthymic temperament is cheerful, over-optimistic, exuberant, with mental overactivity, over-talkative, warm, people seeking, extroverted, overconfident, or grandiose, habitually short sleeper, including in the holidays, with high energy level, fluid planes, over-involved, uninhibited, stimulus-seeking. The cyclothymic irritable. What's the difference? This is a biphasic dysregulation characterized by slight and directive shifts from one phase to the other, each phase fasting for a few days at a time with infrequent euthymia. Common symptoms are mental overactivity, always present, insomnia or bad quality of sleep, somatization, diffusing somatization, with behavioral or subjective manifestation, going to hypersomnia versus decreased need of sleep, introverted self-absorption with uninhibited people seeking, taciturn versus talkative, psychomotor inertia versus restless pursuit of activities, and also lethargy versus eutonia, dulling of sense versus keen perception, slow-witted versus sharpened thinking, pessimistic versus optimistic. The softy, unstable temperament, as I talked before, is a soft cyclothymic temperament, characterized by vague and fluctuating uneasiness, mood instability but of low grade, anxious trait. This is the subgroup that several colleagues depicting as anxious temperament, but because the anxious temperament present always instability, in my experience, is a subgroup of a cyclothymic irritable temperament, but is a softly subgroup. When it develops to up-threshold form of a bipolar disorder, this presents better prognosis than cyclothymic temperament development. Also, Professor Akiskal and Riemer described this important sentence to remark the importance of the temperament, to early catch the temperament. Let's read together. Premorbid affective temperament types have important role in the clinical evolution of minor and major mood episodes, including the direction of the polarity and the symptom formation of acute mood episode. They also significantly affect the long-term course and outcome, including suicidality and other forms of self-destructive behavior such as substance abuse and eating disorder. The symptoms. These are the symptoms we can find in mixed states, 2 or more of these. The symptoms, it's important to catch very, very fine and very together. Depressive mood together with irritability, antisocial behavior, substance abuse, disorder of appetite, a sense of despair and suicidal ideation, anhedonia and widespread apathy, reduced ability to concentrate and mental overactivity, hyper or hyposexual activity, insomnia or fragmented sleep, comorbidity with anxiety disorder, panic, generalized OCD, social phobia, gastrointestinal disorder, IDASH, and various somatization symptoms, colitis, gastritis, diffuse muscle tension. These somatization are very, very frequent. The notion of the mixity. What's the mixity? The mixity is a dynamic notion describing the presence of overlapping symptoms of mixed states in an increasing intensity level. Let's think of a car, for example, with its accelerator and tachometer. By accelerating, we increase the power of the engine. No, it's not the power that the engine emits, and the tachometer rises. At the same time, our car, the intensity of the level of the mixity symptoms is the intensity of the level of the illness. So that it's important to early catch the level of the intensity. And this we can find with a rating scale I created some years ago and then published in 2014. I shall present later. The dysphoric component of mood is quite more frequent, very frequent. Approximately, it includes 30%, between 30-40% of mood disorder of spectrum. However, there are pathologies which are often underestimated or worse, not diagnosed, or bad treated, or inappropriately treated. Why this? Because clinicians find great difficulties in making a correct diagnosis of a mood disorder in mixed states, because the patient mainly focus their own symptoms on depressive uneasiness, inducing the clinician to frequently prescribe antidepressants. I feel bad, I feel depressed, I feel with up-down, more down than up of mood. And then the clinician goes to error. Going to frequently prescribe antidepressants alone or together, worse with benzodiazepine. This inadequate treatment induces the dysphoria. This is the worst symptoms of the bipolarity. Also, Professor Akiskal talked about of mixity. He invented the mixity word. I did not. Akiskal presented this slide in Israel in 2009, describing the mixity of depressive phase. They are the most insidious symptoms of overlapping depression, restlessness, and irritability together can cause increased risk of suicidality. And you can see in this slide of Akiskal the presence of the comorbidity with anxiety or panic, the agitation and restlessness, the irritability and aggression, the activated depression. There's some phases of recovering from depression is the worst moment of the patient when there is also with irritability and aggression and restlessness. The intensity, as I told before, of this symptom can be shown using the rating scale for mixed state, GT-MSRS, simply rating scale to administer to the patient in 11 items with also 7 sub-items to demonstrate the level of the mixity. We can find from 2 to 19 score divided in 3 subgroups: medium, light, medium, and high level of score of intensity of the symptoms. This rating scale that is translated also in Russian, into Russian language. I invite all colleagues to use it and give me your feedback following your experience. The presence of a new rating scale for mixed state is crucial because there were not other rating scales so focused on mixity and mixed states. The other rating scales were focused on bipolarity, on hypomania, on different modality, but not for the mixed states. This utilization should enable the clinician to make an early diagnosis of a bipolar mixed state by identifying the mixity symptoms. And consequently, this should enable early prescription of a mood regulator drug, so to optimize the treatment. I show the rating scale in English, but I repeat, Professor Darasminova has the Russian version. The motto of the clinician: I am a clinician, I'm not a researcher. My life is to do the clinician since more than 25 years. And the motto is, must be, a correct treatment follows to a correct diagnosis. This is must be. Very often, I repeat, an inadequate treatment to use long-time benzodiazepine or antidepressant alone causes an increase in instability and the development in patient of the dysphoric mixed states. So that the bipolar disorder treatment will require spatial care, a combination therapy between mood regulators and low doses of antidepressant, more mood regulator than antidepressant. I described some name of mood regulators. Lithium we know, but above all, carbamazepine, valproate, gabapentin, oxcarbazepine, lamotrigine, topiramate, olanzapine, asenapine, loxapine, and the pipamperon, an ancient new, at the same time, mood regulator. The first of the atypical neuroleptics. And between the antidepressant, I suggest prevalently SSRI and SNRI. I repeat again to my clinical colleagues, never using antidepressant alone or in combination with benzodiazepine, and never use a long-time benzodiazepine, both in order to avoid an increase in instability and the development in patients of the dysphoric mixed states. Since many years, I dedicated myself on spreading this clinical concept among psychiatrists. For example, through this interview of mine in my YouTube channel that has more than 42,000 views. The translation of the Italian title is "To treat depression does not mean to prescribe antidepressants." This is one of the most viewed video in the field of bipolarity in Italy. One important observation from the first validation study on the rating scale, GT-MSRS rating scale, the four diagnoses of recurrent depression and major depression emerged in that study scored within the medium level of the GT-MSRS, showing how the symptoms of mixity are diffused within all mood disorder subtypes, not only in the bipolar classic. In consequence of this, the prescription of mood stabilizer together with antidepressant, even in patients with diagnosis of major depression or recurrent depression, begins crucial for a good treatment. Crucial. Also, Akiskal, in a conference in 2006 in Copenhagen, described this notion. Melancholia, as defined today, is most closely linked with depressive or mixed phase of a bipolar disorder. So that the practice of treating them with antidepressant monotherapy needs a re-evaluation. Let's read what Akiskal said several years ago. Our final comments. The consequence of all I said, the consequence of lack of recognition and the treatment of bipolar disorder can be the reduction in the expectation and the quality of life, the increase in working days, the increasing use of healthcare resources, including for concurrent the comorbidity, concurrent disease. The stable mood then can become chronic and the clinical picture can get worse. And obviously high risk of suicide. Finally, I never get tired or repeat. In consequence of this, the instability of the mood more than depression is the main issue which the clinician needs to deal in the patient with the mood disorder. The depressive episode is only one phase of a broader bipolar spectrum. So that this final sentence I like so much. When considering bipolarity, the notion of a mixity becomes the conceptual reference point of a diagnostic process. All this I said we can find in a book that Mark Edges and myself edited in Cambridge in 2013, The Management of a Bipolar Spectrum Disorder, with more than 55 chapters. And also, with a handbook for population, we created in the same year a handbook for population of mood disorder translated in 12 languages. Darius Vernova also collaborated with us translating into Russian, but we have 12 European languages for this handbook, free download from the website of the European Depression Day. What's the European Depression Day? It's an event that we organize since 18 years in October, every year. And also I repeated that Darius Vernova is collaborating with us since 2 years, and I invite all other colleagues from Russia to collaborate with her to diffuse in several cities this event, because the population needs to understand better and more on mood disorder, on depression, on bipolarity. This is the theme of next European Depression Day, the impact of COVID on depression, because all you know that this has been a very peculiar year, and we'll focus next October on this subject. And finally, thanks for your attention, showing a picture of the Lake of Iseo, where our association is headquartered. Thanks so much.
Thank you very much, dear Professor Giuseppe Tavormina. I would like to express our sincere gratitude for this amazing lecture, and I would like to say and express many thanks for our long-term collaboration already. We are very happy and honored to participate in your conferences and in Cambridge and in Europe, and now unfortunately online, but as the whole world. And we are looking forward to meet you in presence soon in Cambridge, in Europe, in Italy, and we would be very happy to welcome you in our university in Russia, and hope that one day you will come and visit us to Samara State Medical University.
Thank you so much.
And it was very interesting that you said what you said in details about the mixed states. It's a very important topic, yes, and we are thinking about the approbation of Russian version of this mixed state rating scale, which you developed. And we are thinking also to apply this scale to post-COVID patients with affective states, and to think about the group of risks to develop affective states, and to think how mixed states contribute to the severity of affective states associated with post-COVID states of emotional disturbances in patients. Thank you very much, and we will obligatory manage and organize European Depression Day in Russia and join your team. And Associate Professor Alexey Pavlichenko has delivered a lecture during our Depression Day, and we hope that again